It's 7
Facebook
on Tuesday
is
night,
alive.
which means
Sorry,
it's a Q&A, but
I've
it's
just
not a Q&A.
done the video recording on Instagram because it's still kind of, well, I haven't given up on it because I always try, but not working for some reason on Instagram. Anyway, it doesn't matter because I've got all you guys on Facebook and YouTube. So hello everyone, nice to see so many people here tonight. I have got some preordained questions. If there is anyone with a question, then for goodness sake, speak up, because love to do it. Love to answer it here and now. Engagement, yeah. But nevertheless, I'll crack on until something happens. So here we go. What we've got here: can we remove a Baker's cyst? So yeah, I've said before that we can remove cysts from any part of the body. I shouldn't say that because people keep on coming up with all these cysts, and I keep on saying no. So and Baker's cyst is another one. No, Baker's cyst usually on the back of the knee, and it's orthopedics. It's not plastic surgeons. So we can remove skin cysts. I'm not even going to say from any part of the body because there's some parts where we wouldn't, like eyelid, labia, sort of, you know, maybe around the anus. We'd probably be a bit dubious. Hope I don't get banned for saying using that word. Sorry, maybe I should use a different word. But anyway, so there are, yeah, I mean, and also cysts on the hand are often, they can be mucus cysts, which are on the fingers, which are from arthritis, or ganglions, which are around joints, which we can do. We've got Sam at the clinic, who's a hand surgeon, who does those sorts of things, but they're a little bit more difficult, a little bit more complicated. So yeah, so we can't remove cysts. Well, yeah, we can't remove all cysts, and Baker's cyst is one we can't remove. We can remove a lot, though. We remove a lot of cysts, but Baker's cyst is one that would be a no. Can we remove cysts located on the neck? Yeah, that's another one. Mainly yes. I mean, the problem with the neck is when you present with a cyst on your neck, let's be honest with ourselves, you're presenting with a lump on your neck. A neck lump, there can be lots of reasons for neck lumps. So neck lumps is a thing. You know, there's loads of different reasons for neck lumps. So if it is a sebaceous cyst, if it is a cyst in the skin in your neck, no problem at all. But one aspect of it would be ascertaining whether it was a skin cyst as opposed to perhaps something deeper in the skin, deeper behind the skin. So there's lots of reasons for lumps. There can be lymph nodes, there can be glands, especially up here, salivary glands. There can be things like pharyngeal pouches and bits that come off your windpipe and your pharynx and what have you. So weird things. So you've got to be a little bit aware in terms of neck lumps. But as I say, if it is literally a cyst in the skin, definitely we can, but it does need a little bit more thought than perhaps other areas of the body. Yeah, I don't know if you're out there, Amy, but I did see that message from that person. Someone's sent a rude message to us about the milia. So milia, because I mean, what they'd done, they'd inquire about cysts, and then we say, look, send us a photo, and they sent us a photo of these milia, and we say, look, we're probably better off seeing a dermatologist about that, and then they get upset. So you know, that's a bit, and they're like, why are you sending me all these emails when you can't do it? And it's like, well, we'll send you emails. That's cyst removal. And this is a milia. So milia are little like spots, and they are usually multiple. And one of the kind of problems with what we do is we do surgery. You know, we do kind of cut things out, and things like milia often don't need surgery. So there's a lot of things that actually don't get to us, and it would probably be better seeing a dermatologist, because a dermatologist might have some other treatment for them, some more less invasive, if you like, treatments. So if you've got sort of multiple lesions and multiple things, especially very small, perhaps we're not the best, to be frank. We're better at kind of bigger things. So if you've got lots of little things, or like rashes and things like that, then a dermatologist is more of an expert in those sorts of conditions. Whereas when it gets bigger and gets to sort of surgery and things, that's where we come in. So sorry if you feel misled. That person who inquired about the cyst and got told that it would be better to see a dermatologist, but we are, believe it or not, actually trying to be helpful. So that's what kind of happened there. What you got, Bob? I'm in touch with your clinic about removing of a sebaceous cyst on the back of my head. If I go ahead, what's the chance of it reoccurring? Good question, Bob. The problem with cysts is that you need to remove the cyst wall. If you remove the cyst wall, that cyst should not reoccur. Now, some patients are prone to cysts, so you could get another cyst. I don't know if that's obvious or not, or maybe that, but certainly specifically speaking with that cyst, if we remove all of the cyst wall, then that cyst should not reoccur. So what we aim to do is so that's one of the reasons why surgical excision is kind of the final common pathway for cyst removal, because if you burst the cyst or if you lance it or whatever, and the cyst wall remains, it just fills up again. So what we try and do, so that's one of the reasons we have to make an incision about the size of the cyst, rather than just making a little stab in it and like evacuating it, because we have to get that wall out. So we have to make an incision the size of the cyst. We have to make sure we get it all out. Now, sometimes it comes out really nicely, Bob, and we can say, look, happy days, it's all come out nicely. I know I've got all the wall out. You're fine. Sometimes it kind of breaks apart, and it's, especially if there's been infection there, it's all scarred. The edges are a bit indistinct, and it's like, to be frank, you think, oh, crikey, we always aim to get all of the cyst wall out, but sometimes it's difficult, frankly, and sometimes you worry that you may not have got it all out, and sometimes if you don't get it all out, it comes back. So there's not 100%. So pre-op, if you've got a cyst on your head, there's not 100% guarantee that we can say that it's not going to return. However, if it does return, we'll do it again for free. But we have had to do that a couple of times, to be fair. So sometimes, particularly if there's been infection previously, particularly if there's any sort of if it's not a straightforward, nice sort of smooth cyst, if there's kind of inflammation in the area, that's why if it's infected, it's best not to have it removed, because they'll have a nightmare to remove when they're infected. So we want to do it when it's nice and quiet. And when you do a cyst in your mind, or in my mind, I always think, oh yeah, it's going to be beautiful. Get a nice plane between the cyst and the surrounding tissues, and you shell it out, and it all comes out as a nice cyst. But the reality of it is that wall can be quite friable, and you're grabbing it, and the forceps kind of break the wall, and the wall breaks up, and all the contents of the cyst come out, and it's a little bit more difficult then to see the plane between the cyst and the surrounding tissues, because the wall is broken. You can often still maintain that, and even though you break the wall, you can try and still focus on that plane and make sure you get all of the cyst wall out, even if it's come out fragmented. So it might look like a mess, but when you're doing the surgery, you can actually keep on track with that cyst wall and make sure you get it all out. So even if it doesn't come out as one piece, if it comes out as one piece, then you got it all out. But even if it doesn't come out as one piece, you can still be relatively confident you got it all out. So we aim for it not to come back, Bob, is the answer. But there's no kind of 100%, because we don't know how it's going to go in the operation. But if all goes well, happy days. If it doesn't all go well and it comes back again, as I say, we'll just remove it again for you. Can we remove a pilonidal cyst? Oh my goodness me, we've got all the questions of the cysts we can't remove. So that's kind of in the natal cleft, the pilonidal cyst. So it's the top of the natal cleft. And again, can we? That's a question, isn't it? We don't do those cysts. Pilonidal cysts are usually due to hairs on your back. They're usually male people, and if you've got a hairy back, it's a thing, and they fall into the crack, the crack between your buttocks, and then they kind of work their way in and form a little sinus, and they can form an infected cyst. Jeep driver's bum is kind of what they call it. So it's for people, hot and sweaty Jeep drivers, or truck drivers, or things like that. and they can be very difficult to treat. They often get infected, and they can often drag on for a long, long time. Exacerbating factors are being overweight and smoking. The really bad ones are always in people who are overweight and smokers, because they reduce your ability to heal, and so it drags on. And if they get infected, they can form what's called a pilonidal sinus, which is like a connection between the cyst and the skin, and it discharges, stuff comes out, and it gets infected, and it's very difficult to treat and very uncomfortable for patients to experience. And it often will involve laying open, which often means kind of cutting an X and then cutting the corners off the X, so you kind of have a hole there, so that all the evil humours can come out. And you pack it, you put this pack in, and then the pack changes every day. This is something that I did when I was a general surgeon. The district nurse or whatever would change the pack every day, and you just gradually put less pack in, and it's a difficult problem. And only when they're kind of really big or really complicated would a plastic surgeon potentially get involved to sort of cover the defect if there's a big hole there. But the actual management of pilonidal cysts are usually, if it gets to a surgeon, would be a general surgeon who would be involved in getting rid of the infected cyst and maybe laying it open and packing it. So we tend not to do that one. So yeah, Baker's cysts and pilonidal cysts is two of the cysts we don't do, but we do all the other cysts. Well, most of them anyway, not eyelids, meibomian. So next one's going to be, come on, someone asked me about a meibomian cyst. Easy for you to say, because we don't do meibomian cysts. Meibomian cysts are on the eyelid. Where else don't we do? So I'll say labia we don't do. That'd be gynecologist. Your eyelid would be ophthalmologist. Give me a question I can answer. Come on. What's the difference between a shave and excision when having a mole removed? Okay. So first thing, pretty much, I'm going to use some sweeping statement that then I'm probably going to be proved isn't factually correct, but I think this is correct. Pretty much any kind of mole can be excised. So excised means cutting it out and stitching it up. So that's an excision. So an excision is valid for pretty much any mole. If it's a really big mole, it might not be able to be excised and closed. So you might need something else to cover the hole when it's removed, or you might need to do serial excision or something. But most moles aren't that big. Most moles are small and are able to be excised, cut out and stitched up, which is, I think, what most people associate with a mole removal. They think that's what it is. You cut it out and stitch it up. So that's valid for any mole. Shave excision is only for a subset of moles, and the two criteria that need to be met are that the lesion has to be benign, or at least presumed benign, clinically benign. So if we look at it and we think it's a cancer or potentially a cancer, we would not shave it. You shouldn't shave a cancer. If you're worried it's a cancer, you should excise it. So if there's any worry that it's a cancer, shave is off the cards, and it has to be raised. If it's not raised, you can't have a shave. So if it's benign, clinically benign, if it looks like it's not a cancer and it's raised, a shave is an option. Now, excision is still an option. So as I say, excision is an option for everybody, but for flat ones or potentially cancerous ones, excision is the only option. For raised and benign ones, shave excision is an option, or shave. I shouldn't call it shave excision because that's complicating the terminology, but a shave is an option. So a shave takes it off at the level of the base of the lesion. That's why it has to be raised, because if it's flat, you can't need to shave against it. So the difference is the shave will just sort of take the bit of the mole that's above the skin off. So it will give you a flat patch kind of scar, as opposed to an excision, which gives you a line. And there's pros and cons. The shave is kind of less scarring because it's not as deep. It just goes to the level of the skin, flush with the skin. There's no stitches. It's just like a little dressing, because it's like a graze we give you. And we put a little dressing on, and it heals as a sort of patch. Whereas an excision gives a bit more of an obvious scar. It's kind of a line, an excision. So it's a bit more of a kind of obvious what you would imagine a scar to be, whereas a shave is kind of like a patch. So cosmetically speaking, probably a shave would probably look better. Not always, but probably. Unfortunately, medicine's not a precise science, so just have to say usually it looks good. You can't guarantee everyone it's going to look good, but you know, usually it's good. And the bad things about a shave is that if it's pigmented, if it's got color in it, if it's a mole with color, sometimes the color goes deeper than the level of the shave because it just takes it off the level of the skin. So you end up with a flat patch with still color. So you end up with kind of like still a mole really, but it's not raised. Now you might say that's fine because it's just the raised nature that bothers me, but you might be a bit cheesed off with that. You might say, hold on a minute, you haven't removed my mole, it's still there. In which case an excision would be an option. And the other bad thing about a shave or risk with a shave is that if it's got hairs, sometimes these raised moles have got hairs growing from them. If they've got hairs growing from them, often the hairs go level or deeper than the level of the shave. So again, you get rid of the raised nature of the mole, but you still have these hairs growing, and these can sometimes be dark hairs and a bit annoying. So if you're concerned about there being pigment left behind, if you're concerned about hair follicles, then you might choose an excision versus a shave. Often, also, sometimes people don't like the thought of a shave. They don't like the thought that you're only removing the bit that's sort of proud of the skin. They don't like the thought of there being some mole left behind because they think it's going to grow back, or you know, they just want it gone. They don't want the, you know, I don't know, psychologically they just want it off, which is fair enough. They could have an excision. So as I say, anyone who's a candidate for a shave is a candidate for an excision, but it's a bit more of a thing, an excision, because it's like a full thickness cut through the skin, and sutures. You have to come back a week later to have the sutures removed. But it's 6 and 2/3. I'll be honest with you, and the price is the same, and the length of the procedure is similar. I guess a shave's probably a bit quicker, but you know, there's similar sort of length of procedures for a small mole anyway. Some areas might be difficult for an excision on the nose where the skin's tight, so it might, you know, suggest a shave might be better. But you know, maybe the orientation of the lesion might be an issue if it might be favourable for a scar. So I might say, oh, you know, you might want to have it removed. I don't know. We can talk about it. We can rap about it anyway. But that's kind of what we talk about when you come to the clinic. Those two options, as I say, assuming you're a candidate. Not everyone's a candidate for them. Good questions, Amy. Well done. Thank you for the questions over those people who asked them. I will be back again next week, Tuesday night, 7 o'clock, same time, same place. Bob asked a live question, so well done you, Bob. We should stamp your card for that. That's a loyalty scheme. We haven't got one. I just thought of it just now. But if you have any questions, anyone, then do by all means message me. I will do my level best to answer them. And who knows, if you're lucky, it might get on next week's show. So yeah, I'll be back next Tuesday night at 7 o'clock. And without further ado, I'm going to say that's it. Good night and God bless. Go and put your feet up.